Hi, I'm Laurie Sehn from BC Cancer in Vancouver, Canada, and today I'll be talking about diffuse large B-cell lymphoma and what we know so far. These are my disclosures. So I think for all of us who treat diffuse large B-cell lymphoma, we often consider this a very rewarding lymphoma to treat. So R-CHOP, which currently is the standard of care, has the capacity to cure the majority of patients. But unfortunately, 30 to 40% of patients will either exhibit progressive disease or relapse following initial benefit to R-CHOP. And in these cases, the relapses and progression often occur quite early, within the first 2 years after initial diagnosis. Of course, we recognize that diffuse large B-cell lymphoma is not one thing, but can be very biologically heterogeneous. So we've known for decades now that there are at least 2 subtypes of diffuse large B-cell lymphoma that we can define by gene expression, referred to as cell of origin. And these subtypes are the ABC and GCB subgroups. This is relevant because we do know that they harbor oncogenic mechanisms that basically propel the tumors biologically differently, and that ultimately this does translate into a difference in prognosis, with the ABC subtype having a worse prognosis after R-CHOP treatment. Even more recently, we know that the biology or the heterogeneity goes beyond that of cell of origin. So by doing sophisticated studies looking at gene mutations and molecular aberrations, we can now identify that there are further subgroups within ABC and GCB Dlbcl that should be recognized. Of course, currently in clinical practice, we don't have the tools to identify these more discrete subgroups, but hopefully this will change in the future. So it's been a challenge to make progress in the upfront setting for diffuse large B-cell lymphoma. We've seen a series of recent randomized controlled trials that have attempted to introduce novel agents into the frontline setting. And unfortunately, to date, all of these published trials have actually been negative. So R-CHOP has till now remained the standard of care. However, we do know that the POLARIX trial, which has investigated the introduction of polatuzumab vedotin into the upfront setting by replacing vincristine. So this was a head-to-head randomized phase 3 trial that compared Pola R-CHOP versus standard R-CHOP. Well, this trial has not been fully reported yet. A press release has indicated that the trial has met its primary endpoint and is considered positive. So I suspect we're likely to see the data emerging shortly, most likely at the upcoming ASH meeting. But what about the management of relapsed refractory Dlbcl? Well, this, I would say, still remains a challenge. Most of the time in my own clinic, I think through these lists of options when I consider what treatment to offer a particular patient. I think it's fair to say that at the current time, for patients who are appropriate candidates for stem cell transplantation, so patients who are young enough without significant comorbidities, the current standard of care continues to be platinum-based salvage chemotherapy, followed by autologous stem cell transplant. However, we do know that at least half of patients won't be suitable for that approach because of age and comorbidities. And also, even with best attempts, at least half of those that go down that route won't actually go through the transplant because of poor response to chemotherapy, or ultimately can also relapse post-transplant. CAR T-cell therapy, of course, is now a new novel therapy that presents an additional option. This is currently approved in third-line setting and beyond. And although this is still a relatively recently available treatment, I think access continues to be a problem in many centers. It also won't be suitable for all patients. So we know that there's toxicities associated with CAR T that may not be suitable for every patient, depending on their comorbidities and also the biology of the lymphoma. Historically, we mainly had palliative options available that included either single or multi-agent chemotherapy. I frequently use in my own clinic RGDP or some modification of RGDP. But of course, with these, we expect generally only temporary palliative benefit. Radiation therapy might be an option, but of course, it really only offers local control, and most patients have wider systemic disease. And I'd have to say that allogeneic transplant is something that I don't frequently consider. Given the age of the patient, it's really rarely feasible. And based on rapidly progressive disease, usually we don't have time to organize an allogeneic transplant. So the introduction of novel agents, I think, has really been transformative for relapsed refractory DLBCL. This is data from the recent pivotal trials looking at the possible outcomes with CAR T-cell therapy. So I'm not going to be focusing on CAR T-cell therapy today, but will acknowledge that CAR T-cell therapy has offered the potential for durable disease control in some patients. Studies suggest that somewhere between 35 and 40% of patients may actually achieve durable benefit with CAR T. But unfortunately, as I said, this isn't going to be appropriate for all patients. And the reality is that still the majority of these patients will fail CAR T-cell therapy. So it's encouraging to see that there have been additional novel agents that are now emerging into the clinic that allow for durable disease control. The first agent that was approved for relapsed refractory DLBCL was polatuzumab vedotin, which is an anti-CD79B drug conjugate. So polatuzumab vedotin targets CD79B, which is universally present on the B cell surface and is part of the B cell receptor. So it does not need to be tested for on pathology evaluations. Polatuzumab vedotin contains not only the anti-CD79B monoclonal antibody, but also a potent cytotoxin, so MMAE, which when incorporated into the cell leads to microtubular disruption and ultimately apoptosis. So polatuzumab vedotin earned regulatory approval based on the seminal GO29365 study, which was a phase 1b/2 study where it was combined with bendamustine and rituximab in transplant ineligible patients with diffuse large B-cell lymphoma. So the inclusion criteria included transplant ineligible diffuse large B-cell lymphoma, patients who had received at least one prior line of therapy. The exclusions were patients who had received prior allogeneic transplant, had a history of transformation, or who had current significant peripheral neuropathy. The study design included initially a safety run-in of 6 patients that received POLA plus BR, followed by a randomized phase 2 component where 40 patients were randomized 1-to-1 to either receive POLA BR versus BR alone. That portion of the study now has fairly lengthy follow-up with more than 4 years of follow-up available. Subsequently, there was a phase 2 single-arm extension that was performed where an additional 106 patients were treated with POLA BR. Here we have less follow-up where the median follow-up is 15 months. And if we look all told, that leaves a pooled POLA BR cohort of now 152 patients. So just to remind you, in this study, polatuzumab vedotin was dosed at 1.8 milligrams per kilogram and was administered on day 1 of each cycle of standard dose BR. It was administered every 3 weeks for up to a total of 6 cycles. So this is a finite therapy being completed with 6 treatments. These are the results of the randomized phase 2 portion that earned this drug regulatory approval. So the primary endpoint of the randomized phase 2 was end of treatment PET CR rate. And you can see here that in the red bars on the left, patients receiving Pola-BR had a significantly improved CR rate of 40% compared to 18% for patients receiving BR alone. Importantly, that translated into an improvement in overall survival, with the median overall survival in the Pola-BR group being 12.4 months versus 4.7 months for BR alone. So we now have additional patients that allow us to further review the outcomes that can be seen with Pola-BR. So these are the clinical characteristics, not only of the initial 40 patients entered into the randomized arm, but the additional pooled cohort in the entire study. So you can see on the right that within the pooled cohort, there's a broad range of ages of patients that were treated, ranging from 24 years to 94 years, with a median age of 69 years. Patients had received a median of 2 prior lines of therapy, but up to as many as 7 lines of therapy. Importantly, this was a highly refractory group of patients. So approximately 64% of patients were considered primary refractory, meaning that they were refractory to R-CHOP, either progressing through it or relapsing within 6 months, or about 76% were refractory to their last prior therapy. So the outcome curves on the left are the extended follow-up of the randomized phase 2 portion of the study. So now with follow-up of more than 4 years, we can see that the benefit that was seen with the addition of polatuzumab to BR was actually maintained over time. Those curves stay separate. It's also evident that there remains a tail on the progression-free survival curve, where a fair proportion of patients have not progressed despite the prolonged follow-up. The 2-year progression-free survival was 28%, and the 2-year overall survival, 38%. On the right, we can see the progression-free and overall survival curves for the extension cohort of the additional patients that were treated. And although the follow-up here is shorter at 15 months, we can see that the median overall survival of 12.5 months was quite comparable to what we see or saw in the randomized phase 2 portion. So here you can see the outcome in terms of response rate according to line of therapy and disease refractory status. So it's intriguing that patients who are treated earlier, so following 2 lines of therapy, actually have a significantly better overall response rate than patients who are treated in 3rd line and beyond. So patients respond regardless of line of therapy, but the best overall response rate in the 2nd line was actually quite impressive at 74%. Similarly, patients who are non-refractory respond better than patients who have refractory disease. And it's impressive, again, that patients who are not primary refractory or not refractory to their last therapy had a best overall response rate that ranged from 89 to 94%. The additional thing that I think is noteworthy in these bars is that for patients that do respond, they actually achieve quite a deep response. So the overwhelming majority of patients that have a response actually experience complete remission, as you can see by the green bars in this figure. Looking at progression-free survival and overall survival according to line of therapy and refractory status, again, similar to what we might expect, you can see that the progression-free survival and overall survival is highest in patients who are treated in the 2nd line versus later lines of therapy, or also in patients who are non-refractory. I think it is particularly noteworthy that patients who are not primary refractory actually have a median overall survival of 32 months. So what about safety? Well, I think many of us are familiar with giving BR in our routine practice for a variety of lymphomas. The addition of polatuzumab to BR actually did not lead to any unexpected toxicities, I'd say that in general, the primary toxicities were hematologic, and these were somewhat augmented with the addition of polatuzumab. So we learned from the randomized phase 2 portion of the study that the incidence of neutropenia, thrombocytopenia, and anemia is somewhat higher in patients receiving the POLA, but importantly that this did not translate into a higher risk of significant infections or need for transfusions. We know that peripheral neuropathy is a risk with drugs like polatuzumab, and it was seen in about 30% of patients treated in this study. However, importantly, it was generally a low-grade event, so very few patients, 2%, in fact, received or had any higher grade peripheral neuropathy, and in a majority of patients, the peripheral neuropathy was low-grade and largely reversible. So I'd say that, based on these study results, POLA-BR has become a very standard and frequently used therapy in the relapsed refractory setting. In my own clinic, I certainly would consider it as an option for patients who have transplant-ineligible disease as a next-line therapy following relapse from R-CHOP. However, certainly, I think we're all excited about the ongoing evaluation of polatuzumab vedotin in additional combinations as well that may open up future options. So a variety of clinical studies are ongoing, looking at polatuzumab combined with other agents, some of which include non-chemotherapy-based combinations, including lenalidomide, venetoclax, and bispecific antibodies. There are also randomized trials that are currently ongoing in the salvage setting. So R-ICE is a frequently used salvage therapy prior to stem cell transplant in patients who are suitable for stem cell transplantation. And there currently is a study of POLA R-ICE versus R-ICE underway. R-GemOx is frequently used as a palliative immunochemotherapy combination in non-transplant eligible patients. And there is a current trial that will be comparing POLA R-GemOx versus GemOx in this population. So what about other agents that have recently become available for DLBCL? The second agent that received approval was selinexor. This is an XPO1 inhibitor that targets a nuclear transport protein. And when inhibited, it leads to the accumulation of various proteins within the nucleus of cells, including tumor suppressors that lead to cellular apoptosis. Selinexor was approved based on the pivotal SADDLE study. This was a single-arm study that enrolled patients with relapsed or refractory DLBCL who are not eligible for stem cell transplantation. They had to have received 2 to 5 prior treatments, and there was a bit of a washout in the study, so patients had to have been observed for 60 to 98 days without any treatment. So I'd say it probably didn't include patients with the most aggressive biology, but it is an oral agent that gets given twice weekly indefinitely, so it is an ongoing treatment. In this trial, 127 patients were treated, and the overall response rate was somewhat modest at 28% with a CR rate of 10%, and unfortunately only a median progression-free survival of 2.6 months. However, it was generally well tolerated with relatively few high-grade toxicities, the most notable one being thrombocytopenia. General toxicities, however, were largely related to gastrointestinal side effects and fatigue, and these are, I would say, issues that probably will require some supportive care when patients are treated with this agent. The next combination that has received recent approval for relapsed refractory DLBCL was tafasitamab and lenalidomide. Tafasitamab is an anti-CD19 monoclonal antibody. quite similar to rituximab, although in this case targeting CD19, which of course is the same target of CAR T-cell therapy. And in this study, it was combined with lenalidomide, and the combination was designed to hopefully augment the immunomodulatory effects of lenalidomide. In the pivotal L-MIND study, this was a single-arm study evaluating the combination in patients with relapsed refractory DLBCL who are not transplant candidates and received between 1 to 3 prior lines of therapy. The study did aim to exclude primary refractory patients, although ultimately an amendment was created and it did enroll some primary refractory patients. Lenalidomide was administered as per standard dosing for the first 12 months, and tafasitamab, which is an IV therapy, was given weekly for the first 3 months and then administered twice a month for essentially indefinitely. So this is also an indefinite prolonged treatment. So the study enrolled 81 patients, and you can see that the median number of prior lines of therapy was 2, and that only a small percentage of patients were considered primary refractory. So these were the results that were recently published. So the overall response rate was 60%, and the CR rate was 43%, with median progression-free survival being 12.1 months. In terms of the toxicity, this is divided up on the left with the toxicity seen in the first 12 cycles with the combination therapy, and on the right for patients going on to tafasitamab monotherapy. I think it's fair to say that the majority of toxicities are seen in the first year related to the combination and likely largely attributed to the lenalidomide. And really the array of toxicities are typically the ones that we would see with lenalidomide, namely neutropenia, other cytopenias, rash, and fatigue. So the final drug that's received recent regulatory approval for relapsed refractory DLBCL is loncastuximab tesirine. This is an antibody drug conjugate targeting CD19, again, the same target as CAR T-cell therapy. And here the cytotoxic agent is a PBD dimer, which leads to intercalation of DNA and ultimately cellular apoptosis. In the phase 2 LOTUS-2 trial, patients were enrolled in a single-arm fashion. It included patients with relapsed refractory DLBCL who had failed at least 2 prior lines of therapy, so they were somewhat more pretreated than in the previously discussed trials. And in this trial, patients received a higher dose for the first 2 cycles, and then ultimately it was dosed at 75 micrograms per kilogram, administered intravenously every 3 weeks for the first year, and then subsequently every 12 weeks for up to 3 years, but actually there was an allowance to give it indefinitely. So again, a prolonged therapy. In total, 145 patients were treated on this trial, and the majority of which had diffuse large B-cell lymphoma, but a few other aggressive histologies were included. You can see that the median number of prior therapies was 3, and in general, about 60% of patients were considered refractory to their last treatment, but only 20% were considered primary refractory. Here are the response rates. So modest but encouraging response rate of 48% and a CR rate of just under 25%. This led to a median progression-free survival of 5 months and a median overall survival of just over 9 months. In terms of safety, the primary toxicity is really related to cytopenias. However, there was a transient transaminitis that was noted and I would say selective for this agent. So in addition to these interesting novel agents that have actually already achieved regulatory approval, the additional drugs that are undergoing testing are also very exciting. I think the probably next set of drugs that are most furthest along in development and yielding the most excitement have been the bispecific antibodies. I'll just mention one bispecific antibody here, which was recently presented in an updated presentation at the last ICML meeting, and this was glofitamab. This is a bispecific antibody that targets CD20 along with CD3. And the goal here is to bring together the T cells together with the B cells to induce a T cell immune response. So at ICML, we saw data on an ongoing phase 1/2 study presented in which the glofitamab is given for up to 12 cycles of therapy. In the data that was presented, patients had a variety of histologies, including aggressive and indolent B-cell lymphomas, but they presented on a total of 52 patients. And you can see here that the response rates in aggressive non-Hodgkin lymphoma listed on the left were quite encouraging. This was a dose escalation trial, so patients receiving the highest level dosing actually had overall response rates of up to 78% with 71% complete remissions. And although it's still early in terms of follow-up, with the follow-up being only 6 to 8 months, you can see here that for both aggressive and indolent lymphoma, so aggressive lymphoma being the blue curve on here, that particularly for those patients who respond, some of these responses are looking quite durable. But again, I'd caution that in this experience, the follow-up is still relatively short. And in terms of toxicities, the primary toxicities have related to cytopenias and the risk of cytokine release syndrome and neurologic complications has been generally low, and particularly with regards to cytokine release syndrome has been mainly low grade. So to summarize, it's really exciting to see that there have been numerous novel agents that are emerging on the market that are able to overcome chemotherapy-resistant disease in the relapsed refractory setting of patients with diffuse large B-cell lymphoma. That while optimization of frontline therapy remains an important priority and challenge, certainly I would argue that there are huge strides in improving the outcome of patients with relapsed refractory disease with these novel agents. Now that there are numerous options, I think that sequencing therapies will need to consider a variety of factors. And in clinic, I will take into account, I would say, the goals of therapy in an individual patient. I will try and compare what we know about the efficacy and toxicity of the various options and match these up with patient characteristics, including patient comorbidities, taking into account patient preferences when selecting how to use these agents optimally. Thank you.